Well, first, thank you so much. It is such a pleasure to be here today, and today has really kind of got me thinking about potential collaborations, and it truly is exciting to be here, so thank you. So today I'm going to be talking about leveraging technology to specifically study irritability in youth. I have no conflicts to disclose. All of the research I'll be presenting today was funded by the Intramural Research Program of NIMH, and of course I really appreciate the support of my travels here today. So taking a step back, how can we really leverage technology, particularly in youth and in focusing in this child and adolescent panel? And first, as we heard about today, of course we can really measure symptoms in vivo, and as others have referenced, using ecological momentary assessment, and I'll talk more about that in a moment. Building on that, we can also really test behavioral performance. And by this, I'm talking about looking at reaction time in the context of a probe on the phone or attentional measure. And then using that information to not only identify, but then target specific deficits through training, or what we then might turn into a game. And then, of course, there's all of this passive monitoring, which has also been talked about today in terms of measuring various peripheral markers, heart rate variability, tracking movement using GPS and location, and sleep, and using that information along with all of these other clinical and behavioral measures. And then, of course, as we were talking about, really figuring out a way to transmit this information to the field in general and inform clinicians with all of this rich data we have that can kind of really move the needle in moving the field forward in terms of dissemination. So in terms of, and I'm going to focus on these first two, and I'm happy to talk about the rest during our question and answer session. So in terms of the specific clinical problem that I'm going to be talking about today is irritability. And here we operationalize it as an increased proneness to anger and temper outbursts. And in fact, in the past decade or so, there's really been increased attention on the prevalence of irritability and anger in youth. And in fact, it's one of the most common reasons why individuals, and youth in particular, are referred to mental health clinics. So how can we measure irritability in everyday life? So of course, we typically, as clinicians, think about probing symptoms and understanding the clinical phenotype by having a parent report on their child's symptoms, having child self-report, and then, of course, clinicians interviewing either the parent, the child, or both, and determining the level of severity. And of course, this is prone to numerous biases, including retrospective report. So very concretely, a child is coming into the clinic and they have a severe temper outburst in the parking lot on the way to NIH. That surely is going to influence those ratings that we ask 15 minutes later relative to if they had had a particularly good hour or couple of days. So there are these inherent biases in retrospective reports. At the same time, we have to be aware, particularly in youth, that there are these informant effects. So we're asking both children and their parents to report on anger and irritability. And one could imagine some differences in a parent versus a child's perception in how angry they were over the past day. And again, if we're measuring it in vivo, we start to circumvent some of those issues. So as we talked about earlier today, we know that EMA, Ecological Momentary Assessment, is a real-time, digitally based event sampling procedure whereby we can assess the symptoms and clinically phenotype in vivo, in the home, where things are really happening, as opposed to having to rely on these retrospective reports up to a week or so later. So specifically, I'm just going to provide a little snippet of data. What we've been doing with our EMA is prompting children and parents with questions. We prompt them 3 times a day for 7 days at random intervals, specifically because these are children. We don't want to interrupt the school day, so we do it in the morning prior to going to school. Then when they come home from school in the late afternoon, and we work around any potential other events, practices, et cetera, that they have, and at the night before they go to bed. And we work all this out prior to sending them home. So at the most broad level, we found some very simple constructs that we were able to measure. First, symptoms measured by clinical group. We might expect this, but it's good to see in vivo in the field. So you can't even see the gray line here. Oh, good. So these are healthy volunteers. Since the last VEEP, they are endorsing that they were not angry or out of control. The anxious kids are endorsing about 10%. And then the irritable youth are up to, a little more than 10%, closer to 15. Then we ask their parents. It jumps up a little. And again, from understanding the clinical phenomenon perspective, this is really important because oftentimes in the clinic, we interview the child, we interview the parent, and at least with our clinicians, we oftentimes kind of lean a little towards the parent over the child, particularly depending on the age of the child. So this shows some really interesting, meaningful differences that we need to really drill down on to understand. And we, in some sense, replicated this with different questions during the same study, whereby when we asked kids how frustrated were they, the healthy volunteers were not particularly frustrated at the time of the prompt, but then you see the increasing levels for youth with anxiety, reporting on themselves, youth with irritability, reporting on themselves, and then again it bumps up again for frustrated, grouchy, and annoyed mood. Now, transitioning to the second part I want to talk about is how we can test behavioral performance. And so here, what we've been working on is an app, which we've called Comet, with the kind of double entendre of these being comets. And what we're trying to do is inhibit motor response. And the reason why motor response? Well, we know that there's a very specific neural-mediated pathway that we understand from animal models all the way through developmental trajectories in terms of the neural circuitry mediating motor inhibition. And what we're starting to do is develop an app whereby we can assess and probe motor inhibition, and then look at these gold standard tasks that we have in the clinic to see if indeed on the phone we can measure these same potential behavioral deficits that we have lots of data on in bringing kids into the clinic. We also have imaging paradigms whereby you could see further down the road, seeing linkages to potential neural correlates. And I also have an Apple Watch here because in the question and answer session, and I see I have 30 seconds left, we have some future directions whereby we would also be probing heart rate and heart rate variability as proxies for arousal in the context of some of these measures. So, In conclusion, some bottom lines are how are some ways we can leverage technology. I think really drilling down and getting granular on the clinical phenotype, testing behavioral performance, then using that information to identify behavioral deficits, and then using those deficits to develop games whereby we can really build on potential deficits. Then there's this whole realm of passive monitoring that other groups have talked about that could be integrated. And then, of course, as a CBT therapist in particular, I have some early studies in how we can be providing this information to the field to really help clinicians in providing the best and most effective care to their patients. Of course, I want to thank a wide group who has supported this work, and in particular, I really want to highlight Ellen, who has been a true support in all of this work. And thank you all for your time and attention.